Okay, welcome everybody in the Pain, Mind and Movement Special Interest Group to this webinar. I'm Adrian Traeger and I'll be giving you a short lecture on some of the work I've done on education and reassurance for patients with pain. So I'm currently based at the University of Sydney, but much of this work took place at Neuroscience Research Australia, which is another research institution in Sydney. As you know, Sydney's famous for its beautiful harbour. It's also got pretty good food. The Sydney rock oysters particularly delicious, as are the flat whites. Today in particular I'm coming to you not from the University of Sydney but from my home, which is in the northern part of Sydney. Moved here 3 weeks ago, and it's an area that's full of trees and nature and birds, and we're really loving it. As you can see here, my daughter's sweeping up the flowers in her gardening outfit. So back to the topic of what we're going to talk about today, which is reassurance, particularly for reassurance in patients with low back pain. What I'm going to do is talk about the options for clinicians, but also some of our ideas on improving the effects of reassurance. For example, targeting different types of reassurance to different patient groups with differing risk profiles, and also different education strategies for those who are higher risk of poor outcomes. I'll also finish with some future directions in this research area. Before we start, I wanted to show you a motivating example.
So, Doctor, is Peter healthy?
My goodness, you'll be dead within a month.
What?
Oh, Hagar the Horrible, if you keep up that lifestyle of pillaging and giant turkey legs, you'll be dead within a month. Now, on to you.
So, what do you think? Pretty healthy, huh?
Well, Mr. Griffin, let's take a look at your physical results. Ah! There's a spider in here. Now, here we go. Mr. Griffin, you're going to expire in a month. This is your driver's license, isn't it? Now, unfortunately, I'm afraid you're going to die. When you watch these Dean Martin celebrity roasts.
Will you just tell us how Peter's health is?
Mr. Griffin, I'm not quite sure how to say this. Kim Basinger? 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 No. But now, on to the cancer.
Oh, my God.
You are a Cancer, right? You were born in July? Now, on to these test results. My, they're much worse than I thought. My son got a D- on his history test. Now, Mr. Griffin, that liver's got to come out.
What?
It's been in the microwave for 3 minutes. It'll get dry. Now.
Please. Please? We can't take any more stick. Please just tell us, is Peter healthy?
Oh, yeah, he's fine. He's just really fat.
Oh, thank God.
Wait, hang on a second. Did you just say I was fat?
Well, yeah, you are pretty fat.
Okay, this is news to me.
So there you have a fairly ridiculous example of presenting test results in a non-reassuring way. But in the context of back pain, what are the clinicians' options when they're trying to actually put a patient's mind at ease? Well, there are 3 really common ways to do this in practice. The first is to reassure them that they're going to be fine and send them off. Second is to provide them with a diagnostic test result, presuming that that test will be negative. And the third option is to sit down and clearly explain the problem. And I'm just going to go through each of these options briefly and the evidence behind them. So the first one, ensure everyone that they're going to be okay. Certainly logical for someone in pain to tell them, actually this pain doesn't represent serious harm and we think you're going to be okay. But Tamar Pincus and her research group over in the UK did a systematic review of consultations where clinicians took that approach. So they provided empathy, built a rapport. This was in people with low back pain, but others. This one study included was this one by Bill Shaw. And what they found was that emotional assurances such as everything's going to be okay and spending extra time building a rapport with the patient were associated with poorer outcomes. Now there could be this was observational data, there could be some reverse causation there, that people with poor outcomes anyway, clinicians tend to spend more time with. So we don't know whether it's these things that are causing the poor outcome, but it's still an important aspect to know about reassurance. So I'd say the evidence is against simply providing someone with the advice that they're going to be okay. What about with a diagnostic test? Well, another systematic review, this time of randomized trials, looked at the effect of giving patients a diagnostic test that tells them there's no serious pathology. Again, not always in low back pain. This could be in people with non-specific tummy issues and other non-specific health conditions. And what they found was that providing those negative test results also didn't lead to any reduction in distress or reassurance. In fact, there was not only evidence of no benefit, but there was potential for harm, particularly in the studies of low back pain. Here's another way of visualizing the effects of providing negative test results. So the black line at the top is high worriers, the middle line are moderate worriers, and the bottom dashed line are low worriers. And these are patients who have just undergone a gastroscopy exam. So we have levels of worry before the consultation, and then immediately after they're given the results of the gastroscopy, and then 12 months later. The most interesting part about this is what's happening with that black line. So you see a steep drop in anxiety after you receive the news there's nothing seriously wrong. But then 48 hours later, most of that worry returns, presumably because you're still experiencing those symptoms and you haven't been given a good explanation for it. So even the all clear may not reduce someone's fears and worries. So I'd cross diagnostic tests off as a useful way of reassuring patients, particularly with low back pain, which leaves us with providing a clear explanation, and this is something we've done quite a bit of work on. Here is a systematic review of studies that looked at providing education in primary care and compared that to just usual education. So this was sitting down and doing a formal education strategy. We found that that approach did reduce fears and worries about the problem. So in the top half of this forest plot are all the studies measuring distress after providing education, and these are short-term effects, and then in the bottom panel of the forest plot are the long-term effects. And because the diamond is on the left-hand side of that vertical line, it indicates that there is indeed a significant effect of providing education on reassurance. It's a small effect, but considering some of these interventions were less than 5 minutes in duration, we thought that was pretty exciting news. Here's a subgroup analysis on those studies. We found something really interesting when we divided up who was providing the education. We found that the physios up in the top part of this plot here had no effect on reassurance, neither did the nurses, but then look at the physicians. They were the only reassuring practitioners, which was pretty devastating for me, given that I am a physiotherapist by training. So which got me thinking, what's going on here? Why are physicians so much more reassuring? So what I did was I tried to look into this problem a little bit more. Maybe it's because doctors look just a bit more credible. They're more believable when they're giving this advice and reassurance. So I decided to dress up to my consultations. I randomly allocated what I would wear, either a snappy suit, if you could call it snappy, or just the traditional physio attire, and I looked at whether I was more believable in the suit versus the physio garb. And what I found was it had no effect whatsoever. So it's obviously not just because physicians look more credible. There's something else going on. Perhaps the content that they're providing is different. Maybe it's because it's Dr. So-and-so providing their advice. Maybe it's because they're a family doctor that's treated that patient for many years. Nevertheless, the evidence is in most support of patient education, in particular brief patient education. There was no extra benefit of intensive patient education. But considering those effects are quite small and we haven't got any evidence that education alone can change outcomes such as pain or disability, what do we do with the patients that are really worried? And what else can we tell them about their prognosis apart from that it's generally positive? So moving on to improving effects, I'm going to start with discussing prognosis. So we now have the ability to be able to assess someone's prognosis with reasonable accuracy in a consultation with someone with acute low back pain. So this was a tool we developed. It involves asking your patient 5 questions. I'm not going to go through what the questions are because it's not particularly important for this talk, but needless to say, these 5 questions give you an estimate of how likely it is that patient will go badly. The question then is, what do you do with that information? Do you tell that person with a 64% chance of developing poor outcome that they have a good prognosis? I'd say probably not. On the other hand, if someone fills in those 5 questions and their risk of poor outcome was 5%, perhaps that's really reassuring information. So this sort of prognostic information and using a prognostic tool, there are other ones like the StartBack tool, it could be a really nice way to enhance reassurance. Here are the usual guideline messages. Acute pain usually improves within days or weeks. For that person with 65% chance of poor outcome, I'd say that statement is not true for that person. So maybe we need to think about this more and start using these tools. The second way to improve reassurance is through a different type of education that's specifically aimed at reducing fears and worries about pain, and that is pain education or explaining pain. So we're trialling this in patients with acute low back pain at the moment, and we've finished the trial and we're writing up the results. Unfortunately, I can't reveal them in this talk, but stay tuned for the results of the PREVENT trial, which is explaining pain for patients with acute low back pain. Briefly, what we did was we randomized 202 people to receive either explaining pain for 2 hours or a control, which was reflective listening based on a Rogerian approach to counselling. It wasn't Rogerian psychotherapy, as many people pick me up when I present this. We weren't trained psychotherapists, it was just using elements of that approach. So in the control group, they received no advice or information. The information we were giving to the patients in the intervention group was based on this idea that an increase in the threat value of pain increases pain intensity, and a decrease in the threat value of pain decreases pain intensity. So really what we were trying to do was change the meaning of pain for people participating. Here's the model in a diagram format. So we think pain education reduces threat, and we measure that by measuring things like catastrophizing, self-efficacy, and unhelpful back beliefs. And we plan to test whether changes in these things as a result of pain education can impact on things like pain intensity. And the explanatory model, this is just one element of what people receive in their 2 hours of explaining pain. But we use a diagram to show people that there are the nociceptive aspects of back pain, but there are also all these other things that influence pain, and we individualize it to the participant based on a history and a physical examination. So we draw things in around here. These are the contextual factors that could be influencing how much pain you're feeling at the moment. So we explain that there are signals coming from the back that could be from some slight tissue irritation, but there are also lots of other things that can be influencing the pain itself. And we think that dissociating pain from damage is a really reassuring thing to do. So we'll see how all that comes out. And that's really all I wanted to say about those things. So I'm interested in getting everyone's thoughts in the forum on what they think about that approach as an approach to reassurance. Also, some of these questions would be nice to get your thoughts on. Do you think discussing things like prognosis is appropriate, and percentages such as a 64% chance of developing chronic pain? Is that a good idea or a bad idea? Can the risk estimates be reassuring, or do you think they're going to do the opposite? Are enhanced consultations in primary care, like where you explain pain for 2 hours likely to be enough for people who are really distressed and have a lot of things going on in their mind that we know can lead to poorer outcomes. Also, do we need to not give diagnostic test results altogether? Maybe we can provide some diagnostic test results, but reframe how those results are presented to the patient. And also we need to know what are the key mediators that determine whether someone is actually less worried after a consultation with a health practitioner. So I'll leave it there. I'll acknowledge all the people that have contributed to this work at Neura. Here's the group here standing at the Bottling Club for our Christmas party. And they're a wonderful group of people, so I acknowledge all of their contributions to this work. And I look forward to the discussions on the website. Thanks for listening.